Kidney stones are extremely prevalent. About 1 in 11 people in the U.S. are going to be affected by kidney stones, and men are by far more likely to have kidney stones than women, okay? And you can see in certain high-risk populations, it can even be as high as 1 in 5 people. So, I mean, you guys know 5 or 10 people, so, or 11 people, so one of those people are going to have a stone in their lifetime. The thing that is happening that we don't really understand why, the prevalence of kidney stones is increasing both in the US and globally, and we ask ourselves, why is that? And we don't know. People have suggested it could be dietary changes, it could be diabetes and obesity, which are risk factors, and even climate change has been implicated for lots of reasons. So part of it, you know, what's the #1 treatment of kidney stones? Do you guys know? Without me getting into it here in a second. The #1 thing you do to treat kidney stones. That's more UTIs. Nope. What'd you say? Fluid, 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 period. That is the treatment of kidney stones, and then I can tell you all kinds of other stuff that we can do. So, you know, hypothesize why climate change could be an issue. If it's really hot outside and you sweat like a pig and you're dehydrated, that could be a risk. What are the chances of you getting another stone if you've had one? Well, it's pretty high. You can see in men, I don't know if this cursor, can you see it? Yeah. You can see in men are more likely than women to have a second stone after their first one. And you can see the farther you go out, the more likely. So at 1 year in general, it's about 15%. At 5 years, somewhere between 35 and 40. But at 10 years, half the people have had another stone. That's a lot. Think about it. I mean, 1 in 11 people or 1 in 5 people have kidney stones, and then of those, 50% are going to have it. I mean, that's a lot of people. This is the other reason why it's important. Not only are kidney stones extremely painful, but kidney stones are extremely costly. All right? If you just stop and think, we spend how much money on all different types of diseases in the country, right? We spend way too much on healthcare and have terrible outcomes compared to other countries. So kidney stones are part of the problem. Look, $2.1 to $5.3 billion per year, and that's an estimate between what we call direct and indirect cost. So the direct cost you can see are from the ER and actual procedures and medications. Indirect is just work loss and productivity loss, okay? So it's a huge problem. Not only is it painful, but it costs a lot of money. And the other problem is kidney stones tend to hit people in their peak working age, people in their 20s to 60s. So very expensive. This is the composition of stones. Calcium stones are the most common. There's calcium oxalate and phosphate. Oxalate is the most common. Phosphate is then the next common. Do you guys know what cystine stones are? Cystinuria? Yeah. So what's that? Yeah, it's a genetic mutation problem. What leads to, what happens? Do you know? In the urine, right? Yeah, it's the basic amino acid transporter in the proximal tubule doesn't work, so you don't reabsorb a lot of amino acids, and then cystine is one of the problems. And so you get a lot of cystine in the urine, and the only reason you guys need to know this, look how rare this is, 0.7%. On your boards, they're going to show you a urinalysis with a urine microscopy of a hexagon-shaped crystal, and they're going to say, what does this patient have? And all you need to see is that crystal and know they have stones, and you know it's a cystine stone. But that's your pearl, you'll see. Uric acid stones are common. In fact, if you had to choose a stone, let me ask you this question. If you guys had to have a stone and you got to choose the composition of the stone, which type or would you want? Which subtype would you choose? Yeah, I must be because I've said it. I know I screwed the answer up there, right? I gave it away. But why is that? Why, uric acid stones form in acidic urine, So anything that forms in an acidic urine is great because I can alkalize your urine. I can give you bases and alkalize the urine, and I can cause that stone to dissolve and go away, and then boom, no procedure, no anything. Okay, so uric acid stones are, in my opinion, the way to go. Struvite stones, do you guys know what those are? Ammonium or magnesium ammonium triphosphate, right? Struvite. So those are usually associated with infection, usually with bacteria that have urease, and they split urea and then increase the pH, so they form in more basic urine. And then you can see calcium phosphate or the mixed stones, okay? But the vast majority, 80% or so, are calcium, some version of calcium, okay? So what do you do if someone shows up on your doorstep and they have kidney stones? What's the evaluation? Do you guys know? Well, there's a few things you can do, and it really depends, I guess, where in the process the patient's presenting. Are they presenting with a symptomatic stone in the emergency room, or are they showing up in your nephrology clinic with a history of stones, or, you know? So I guess I'm one slide too ahead, sorry. I made this and forgot the order, but I'll get to that next slide. But these are questions that I ask myself. In fact, I almost put Dr. Selby's approach, but I thought that sounded arrogant, so I stopped. So questions you ask yourself when you see a patient. Is the stone metabolically active? What does that mean? Does that mean is there radiographic evidence of new stones or radiographic evidence of existing stones that are growing in size? Or does the patient tell you, yeah, every time I pee, I see gravel or feel gravel? You know what that means? And that's a true medical nephrology term. So these are just small little crystals. They're not true stones, but they can feel kind of like a gritty urine coming out, okay? So the patients will tell you, yeah, I pass gravel every so often. Then the next question you ask yourself, are they surgically active? Meaning, do they have unrelenting flank pain or colicky pain or unrelenting stone obstruction causing hydronephrosis and kidney dysfunction? Or is the stone infected, so they have recurrent urinary infections? You treat them and it doesn't get better, and finally you scan them and they've got a stone. And you say, well, maybe that stone is infected and is a nidus of recurrent infections. So that would be surgically active. You ask yourself, what's the composition? What are the risk factors? Why are they forming stones? And then what can I do about it? So those are the questions that I ask myself. Here's what I meant to say on the other side. So there's a few things you do. We'll get a renal panel on these people, and we'll make sure, one, the kidney function is normal, but we'll see what their bicarbonate. Do they have a acidosis or not? What's their phosphorus in the level? What's their calcium? Maybe they're hypercalcemic because they have a primary pituitary adenoma, and they have tons of calcium oxalate stones or phosphate stones, and all I have to do is remove that parathyroid adenoma and, you know, clean out the stones they have, and they're cured. You always want to get a uric acid. A lot of calcium stones can start, the nidus of the stone can actually be a uric acid stone that can then develop calcium layers upon it. So you'll get these calcium oxalate stones, and when you do a stone analysis, you'll slice through it and see that part of it is, some small percentage of it is actually made of uric acid. And of course, PTH for the reasons I just said. And then you always want to check vitamin D. And then we do urine labs. We do a urinalysis, and you can look on the microscopy and you can see if there's any crystals there, and that may help you pinpoint what type of stone they're having. If you're concerned about infection, you'd want to make sure you get a urine culture. We always look at urine pH because some stones, like I mentioned before, are dependent on your pH. They'll form either an acidic urine or basic urine, and some stones don't care what the pH is. Like calcium oxalate, could have high or low pH, doesn't care. Calcium phosphate likes basic or high pH urine. And then we do a 24-hour urine collection. We do something called a supersaturation study. It's a 24-hour urine collection, and essentially we measure the sodium, the calcium, the phosphorus, the citrate in the urine, oxalate, uric acid, all these different things, and it can tell us how saturated the urine is for these different crystals. And then we can do imaging. The CT scan is the most common. KUB is the more historical. KUBs aren't very accurate in that you can have some stones are radiolucent and some stones are radiopaque. What's a radiolucent stone? So you wouldn't see it on a plain film. or uric acid, you wouldn't see it, but calcium stones you would. So you know the K is the perfect way of getting it. So the non-contrast CT is the way to go. Why is it non-contrast and not contrast?
You don't want blood supply light up.
Huh?
You don't want blood supply light up. You're trying to see stones.
Yeah. What color are stones on a CT scan?
White.
White. What color is iodine-based contrast on a CT scan? So if you give someone iodine in their vein and then it gets filtered in the glomerulus and then into the urinary, the renal pelvis and the urinary system, you can't tell what's a stone and what's contrast. So you've eliminated your ability. So it has to be a non-contrast. That's what we call a stone protocol CT scan. And then we do kidney stone analysis. And anyone worth their salt actually does this, because if someone comes to you and says, Doc, I never want to have one of these ridiculous kidney stones again, the best way to answer how to prevent it is to know what type of stone it is, because once you know the stone, then you have some treatment options. All right, I don't know if this will work. I was going to show you. I couldn't figure out how to get the CT scan to actually load in PowerPoint, because I'm still not good at PowerPoint when it comes to that. Do you guys know what Radiopedia is? Greatest website in the world. Do you know it? Yeah, I love it. I love it. Anyhow. Okay, let's go through the CT scan. What's this? Huh? Heart. Good. It's not a trick question. What's this? Okay. What's this and this? The lungs, right? And that's, I think, probably your esophagus right there. And then this is the liver, right? What's this thing? Yeah, that's your stomach. What's that? Spleen. There's a kidney and there's a kidney. And we'll come back and look at that in a second. What's this? What's that? This patient has oral contrast. That's why it's white. That's an intestine. That's a small bowel. There's the pancreas, right? You know, the more you look at CT scans, they're really easy to look at. They're not hard. You just have to look at them a few hundred times, and then it's true. It's like anything in medicine. You just have to do it a few hundred times, and it's fine. But look at this kidney right here. Okay, that's the left kidney. So let's just go from, we're cutting it in half from the top to the bottom. Tell me if you see a stone. I didn't see one, did you? Okay, this is the bottom of the right kidney. So we're going to work our way back up. Tell me if you see a stone. Yeah, see? Well, it wasn't hard. One of my stone research projects, I had to look at about 1,000 CT scans and measure every stone that was in each CT scan. And so I got really good at measuring stones. That is a big one. That is a big one. But that's in one of the calyces probably of that kidney. There's no hydronephrosis, right? That would be the other thing we'd be looking for. But anyhow, I just wanted to show you that just for, I thought you guys would like to look at an actual image. So how do acute symptomatic stones present? It's not a trick question. This is blood in the urine, so gross hematuria or microscopic. What else? Flank pain. And where does that pain radiate? To the groin, usually. And then let me ask you a question. Is that pain constant, or does it kind of come and go? Is it, in other words, is it kind of like described as a colicky pain or not? It's more colicky. It kind of comes on in waves, okay? There probably is a mild constant portion, but it'll have ramping episodes of severity, okay? Some people will tell you they saw something pass or they could feel something passing, okay? So what do you do acutely? So let's say someone comes in the ER, a right flank pain, radiating to the groin, gross hematuria, CT scan shows, 6 mm stone in the right ureter, mild hydronephrosis on that side. What do you do? Huh? I tell you what, if you don't start with pain management, the patient's going to get a new doctor is what they're going to do. So yeah, pain management. So you want to control their pain. You better use a narcotic. Go ahead. Yes, sir.
Do you have NSAIDs on there? Or are you sure? I don't know. I'm just asking your opinion on that.
Okay, good question. So you could try Tylenol. Let's say you have, it would depend on the scenario. In general, you're going to use NSAIDs, and I'll tell you the NSAID I'm talking about in particular, or you're going to more often not use narcotics. It's that severe level of pain. Tylenol will help control pain, but usually, what's the max dose you can give at any single time? It's 1,000 milligrams. And so a lot of people will tell you, I take Tylenol, it doesn't do me any good. Whether that's true or not is another statement, but not everyone believes acetaminophen gives the most relief. So what is an NSAID? What is the standard NSAID that's used? And I am a nephrologist. It makes my blood curl, but what is it? Toradol. It's ketorolac or Toradol. They give it IV or IM, 30 or 60 milligrams, a big slug, and that really does help. And there's studies that show that. Often they're nauseated, so you give them an antiemetic. And then we talk about something called expulsive therapy. So we're talking about therapy that theoretically will dilate the ureter. So anything that will help cause vasodilation of the blood vessels, the relaxation of the smooth muscles. So we talk about using tamsulosin a lot, which is an alpha blocker. We even talk about using calcium channel blockers. The evidence behind whether or not these actually dilate the ureter and at all assist with an acute symptomatic stone passing is questionable. Some people say yes, some people say no. And then we can physically go in and remove it, and the most commonly way is we do a ureteroscopy. So camera in the bladder, up the ureter, and physically remove it. Long term, what can we do? Depending on the location of the stone, we can do lithotripsy. We can still do ureteroscopy, or we can do percutaneous nephrolithotomy or an open nephrolithotomy. So patient lays on their back, small incision in the back, camera through the musculature in the back, an incision in the kidney, into the renal pelvis, and physically remove the stones. Or you can do it open, so that's laparoscopic, or you can do it open, just a big incision, and go in and do it. Not pleasant. People don't like it. Or you can do medical therapies long term, so that's what the urologist does. I'm not a urologist, right? So this is where I get involved. I get involved in the medical therapies for stones. Why did they form the stone? What kind of stone is it? How can I prevent them from having another one? And this is the zone that I live in. Where can stones form? You can get calyceal stones. You can get pelvic stones. You can get uretopelvic junction stones. We call UPJ stones. You can get ureteral stones, or you can get stones in the bladder, or right at the junction where the ureter and the bladder, we call the UVJ junction. So these are the tight areas. So where do stones normally get caught? It's usually up at the uretopelvic junction. That's the main reason, but you can also see it at the uretovesicular junction. And you can see it here where the iliacs are crossing. There's a little bit of compression of the ureter. So you can also sometimes see it there, but the number one site is actually more near the bladder. So does it matter the size of the stone when it comes to what stones are going to pass spontaneously without you doing any procedure? Of course. The larger the stone, the worse chances the stone is going to pass. And then we go by location. If the stone is up here in the more proximal part, proximal meaning closer to the kidney, more likely to pass. The further down it is, the less likely it's going to pass. So if you have a large distal stone, chances of it passing spontaneously are not good. So just in general, regardless of location, here's your general idea of what are the chances of a stone passing spontaneously in 4 to 6 weeks. So I show up in the ER with my horrendous right flank pain and the 7, 8 millimeter right ureteral stone. Well, if it's 8 millimeters, it's about 50-50 chance it's going to pass on its own. within 4 to 6 weeks. You know, not every patient's going to last 4 to 6 weeks to let it happen, so you may have to go get it. That's how you do it. This is what it would look like. This is a basket stone extraction. I'm always impressed that the urologist can find the opening to the ureter. I don't know if you guys have ever seen a cystoscopy done, but to me, it all looks like bladder wall. So I'm not sure how they're able to do it, but they can. Do you guys know what lithotripsy is? So patient has a stone in this right kidney. They lay in this room. This is usually done in a procedure room, and the doc and everyone in the room and the patient have earplugs. Why? Huh? Well, it's loud, right? That's why you wear earplugs. Why is it loud? Yes, we're using sound waves to break up a stone. And so there's a bag of fluid that gets pushed against the tissue to allow the sound waves to transfer through that medium to the skin. Without it, you won't get as effective transmission of those sound waves. It's a spark plug essentially in here. And every time that spark plug goes off, it sounds like a shotgun went off. And it goes off multiple times a second. And this can take 20, 30 minutes to happen. So if you didn't have earplugs, you'd walk out deaf. Okay, it's very loud. And this is what it would look like. So on the monitor, the urologist has essentially a video game where he's moving the target and he's focusing. So right here where this target is over this stone, this is under fluoroscopy, he's targeting the stone. Now, complications of this, what would happen, do you think? Do you think the stone gets hit with this focused sound wave and eventually it breaks up? So what do you think are some complications that could happen here? Anyone?
Depending on the composition of the stone, can't you get like super sharp fragments?
Well, no, but some stones, like there's calcium oxalate monohydrate and there's calcium oxalate dihydrate stones. The monohydrate stones, the urologist will tell you, are the worst stones in the world to break up. They're very hard, whereas the dihydrate are easier. But what happens is two things. One, the stone will break up and it's in the ureter. So what can happen is you get what is it? I'm going to say it wrong. Strunhaus, it's the German word for cobblestone street, essentially. And so what happens is the stones, these little tiny fragments, all of a sudden pile up and obstruct the ureter. So you took care of the stone, but now they still have the obstruction. So sometimes we'll put a stent in. Other things you'll see is some bleeding, and there's some thought is what are the long-term effects of this sound wave hitting the kidney? I mean, it's not just hitting the stone, it's also hitting the adjacent parenchyma. Well, that's the thought that there could be some mild damage. This has really fallen out of favor for the most part. It is reserved for some cases, but in general, we don't do this anymore.
What's the success rate?
I can't tell you off the top of my head. It depends on the type of stone.
Because they don't have a microtube.
Yes, so the question is, what is the success rate with extracorporeal shockwave lithotripsy? I don't know the exact numbers. It would depend on the size and the type of stone, but I can't quote you numbers off the top of my head because this is not something that I do on a normal basis or did on a normal basis. All right, now we get to PEMP. Everyone paying attention? Here we go. Boy, that's really small. Sorry about that. Severe right flank pain, chief complaint. I'll just read this to you. You don't have to. We're going to do the abbreviated version. So it's a 40-year-old female in the ER with a one-day history of severe right flank pain, along with intermittent episodes of gross hematuria. She had a kidney stone at the age of 35, so 5 years ago. And so she went to the ER then and was treated conservatively. You know, she got IV fluids, so fluids, expulsive therapy, pain medication. She was able to pass the stone. Since then, she's had 4 additional kidney stone events that were symptomatic, and she's never been able to capture these stones for analysis. And she was advised to increase her fluid intake, but to help prevent future stone formation, but no one gave her any other recommendations. And you look at her past medical, past surgical history. She's got morbid obesity, status post Roux-en-Y. She has hypertension, hyperlipidemia, and then recurrent nephrolithiasis. What's a Roux-en-Y? So it's for so some people believe gastric bypass surgery or bariatric surgery can cure diabetes, although the data I think now is saying that it may get better, but not completely. But it's for obesity. So this lady had obesity and underwent a malabsorptive and restrictive bariatric surgery. What are the types of bariatric surgery? There's malabsorptive and there's restrictive, or the combination of the two. So like stomach stapling would be an example of restrictive. So I take the gastric antrum and essentially staple most of it so that the food, as it enters from the esophagus into your stomach, can't get to the vast majority of the stomach. There's a little tiny stomach, okay? And then that is hooked up to the duodenum, right? And then you can have malabsorptive. So not only, so what I do there is I set up usually a Roux-en-Y. So I take the duodenum and I disconnect it from the stomach, and I take part of the jejunum and I pull it up and attach it to the stomach. So what I've done is I bypassed the duodenum, or at least part of it, depending on how they do it, part of the duodenum. And so now there's a malabsorptive component. So there's less bowel available for absorption of nutrients. So even if they eat a lot, they're going to have malabsorption. They're going to poop out a lot of their food, okay? So she's got vital signs. She's hypertensive. Why is she hypertensive? Simple. Pain. She's hypertensive because she's in pain. Generally, she's in severe pain. Lloyd punch, right? It's not called Lloyd punch. I don't know where the heck people at KCU got that. That is such an old term. I've never heard of it till I came here. Anyhow, it's called costovertebral angle tenderness, okay? That's how you document it in the 21st century, not positive Lloyd punch. So a lot of people are like, what the heck are you talking about? So that's my commentary, sorry. You do labs. BUN's 25, a little bit high. Creatinine's a little bit high, or borderline. Uric acid comes back normal. You do specific gravity. Is that high or low? Does anyone know the range? Yeah, that's about as high as it gets. So what are we saying? Elevated BUN creatinine ratio, high specific gravity. We're saying that this patient looks volume depleted. Then you look at the urine. What do we see here? Lots of microscopic hematuria. Why does she have white cells? That's a urinary infection, right? She has a urinary infection, right? She has a urinary infection. Don't make me say it again. She doesn't have a urinary infection. She doesn't have a urinary infection. No. So don't be fooled by this, okay? It's possible on your differential she could have a urinary infection, but more likely is that she has substantial amount of hematuria. And when you get enough red cells spilling in her urine, you get other things, including white cells. So that's probably a bit of a red herring, okay? That's clinical experience, so don't get too worked up about it. You do a CT scan, and she's got a 6 millimeter right proximal ureteral stone with mild hydronephrosis, but then you see she has multiple bilateral stones. And the largest one is 8 millimeters. Take a snapshot. I'm about to pimp you, okay? Who wants to answer this? I told you what her stone was. I said it very quickly in one line, and you should have picked up on your board exam what the stone was. I told you the stone. You didn't even analyze it. You have the 99% probability of what the stone is based upon what I told you, and I said it very quickly and briefly. What is it? Ooh, I might accept that as a second answer, but it's not uric acid. It's not the first one. It could be uric acid, but it's not. Calcium oxalate. Dr. Staudinger wins. Why is it calcium oxalate?
Because it's most common and it's most likely to be correct.
It is calcium oxalate, but why is the question?
So in my mind, I would eliminate uric acid because her uric acid levels are normal.
Okay.
And yeah, calcium oxalate is.
So what are the chances she has cystinuria? So in general, unless they show you a hexagon-shaped urine crystal, just forget it, okay? Could she have an infection? It's possible, but usually these people are going to have these histories of recurrent infection. You know, I take my antibiotics for 3 days or a week or 2 weeks, and then within a week later, I'm back with another infection. It's always the same species with the same sensitivities. So less likely. Phosphate, these are common. Uric acid's possible, but why, the correct answer is this, but does anyone know why? What did I tell you? Huh? Bam, the bypass. It is. The gastric bypass comes with all kinds of complications. You need to learn them because everyone has them these days. Now, Roux-en-Y has fallen out of favor. When I was a medical student, this was the rage, but this has fallen out of favor. But particularly Roux-en-Y with the malabsorptive, they get something called enteric hyperoxaluria or secondary hyperoxaluria. Have you ever heard of that? You ever heard of primary hyperoxaluria? No? Okay. So they're completely different, primary and secondary, or secondary is also called enteric. So primary, the problem is you get elevated levels of urine oxalate because of a genetic mutation in one of 2 enzymes that metabolize oxalate. So oxalate is in your food. What is it? What types of food have oxalate?
Blueberries.
Not blueberries. What'd you say? Leafy greens and chocolate. My wife loves chocolate. Chocolate, leafy greens are the big sources, but it's in almost everything. So you eat it, and normally that oxalate is metabolized in the liver with these enzymes. But if you have genetic mutations in those, then you don't metabolize them, your oxalate level, your plasma oxalate level goes up, and then ultimately that causes your urine oxalate levels to go up. And you just supersaturate your urine with oxalate. Any calcium present, they bind, boom, calcium oxalate stones. Not all that common. This lady doesn't have that, okay? This lady has enteric hyperoxaluria or secondary, whatever you want to call it. So how does that happen? So normally when you eat food, there's oxalate in your food, and there's other things like calcium. Normally the calcium in your food will bind to the oxalate in your food and precipitate calcium oxalate, and you poop it out. Now what happens when you have a malabsorptive state? You have steatorrhea. So you get saponification. What's saponification? Oh man, you guys are closer to saponification than I am, so if I ask it, you have to know it. If I know it, you have to know it. So it's calcium binding, you know, in fatty tissue usually is essentially the simplistic. So what happens is instead of the calcium that would normally bind your oxalate in your food and thus prevent you from absorbing oxalate through your gut wall into your bloodstream, that calcium is now binding to your fat in your stool because of this steatorrhea, this malabsorption. So all of a sudden this oxalate is now free to be absorbed through the gut wall and raises your plasma oxalate levels, and then ultimately your urine levels, and then any calcium in the urine, it binds calcium stones. I saw a gentleman who was a nurse from Springfield who came to see me for CKD. His creatinine was, 192, something like that. And I went through all my standard questions on him trying to figure out why he had kidney disease. And I couldn't figure it out. And then finally he told me he had a gastric bypass. I said, no, tell me about that. What did you have? He goes, I had a Roux-en-Y. And I've lost like 200 pounds. I said, great, good for you. And then I quickly ordered a plasma oxalate on him. And his plasma oxalate was sky high. So we then put him on a low oxalate diet and then had him take calcium supplements with his meals. So I'm giving him so much calcium every time he eats that it binds that oxalate. And he got better. So he had calcium oxalate stones, but he also had calcium oxalate nephropathy, which is another thing you can see, but that's beyond this talk. So that's the correct answer. The Roux-en-Y leads to this enteric hyperoxaluria. Calcium phosphate stones, they tend to form more in alkaline urine, and this urine pH was toward the acidic side. Uric acid stones have been reported in gastric bypass because they can get a metabolic acidosis and thus potentially have an elevated urine pH, but not in this case. And then cystine and magnesium, just unlikely. There's a stone. How would you like that passing through your ureter? You can see they come in different shapes, right? You know. Here's your board, Pearl. Dumbbell shaped. It's calcium oxalate, but specifically the monohydrate version. Whereas the dihydrate version are these envelope shaped. See the envelope? They're both calcium oxalate. They may show you both, but that's how you differentiate the dihydrate and monohydrate. Versus calcium phosphate, which just kind of a random crystallization. All right, we're not going to do this. We can come back and talk about it if you want, but let's do another case. So I got tired making my cases, so they got shorter. Sorry. 62-year-old female, history of colectomy for IBD. So what inflammatory bowel disease is cured by colectomy, theoretically? Ulcerative colitis, although they can still develop primary sclerosing cholangitis, right, which is a liver complication. But this lady had probably ulcerative colitis. So now she has an ileostomy. What the heck is an ileostomy? Right, she doesn't have a colon anymore. So she has small bowel. And the last part of the small bowel is the ileum, right? And then we drain that ileum, a loop of it, up to the wall of the belly, poke a hole through the wall, and now she has a bag, and that's where her stool collects. It's a miserable existence, okay, if you've ever seen these people. They have to carry the bag. So imagine going to a restaurant, and then your bag fills up with liquid poop, which is what it is. It's always liquid. And then if it's not sealed well, you might start leaking. Like, it's just a terrible thing. This lady, though, not only does she have an ileostomy, she has high output ileostomy, meaning that ileostomy is just pumping out tons and tons of fluid. So these people often are dehydrated, hypovolemic, orthostatic, and she's had recurrent kidney stones. My question to you is why? And what is the stone? Partly, any stone, if you're dehydrated, the reason why I said fluid was the treatment of all stones no matter what, and if you do that, you'll probably be fine, is because you drink enough fluid, you dilute your urine enough, it's just not saturated to the point where you can form urine crystals and then stones, okay?
Can that dissolve them before you have them?
No. It just prevents them potentially from getting bigger or prevents new ones from forming. But so that's part of it, is she's probably chronically volume depleted. But what is the other complication of ileostomies? Does anyone know? This is not a phosphate issue, but and I'll tell you why in a second. Okay. Anyone? I can tell you, but I like to pimp you. So it's not infection. That would be more with the Struvite, the magnesium ammonium triphosphate. So the problem with ileostomy is, you probably remember in the small bowel, if you think about transporters, I'm a nephrologist, like to talk about transporters. There is a transporter that absorbs chloride and a transporter that it secretes bicarbonate. So this person, they typically develop metabolic acidosis, okay? Typically a non-GAP metabolic acidosis. And so when you develop an acidosis, you then potentially are going to raise or you should theoretically, lower your urine pH. You should make it an acidic urine, right? You've got an acidic blood, you should pee out some of that acid. So what stones form an acidic urine? Uric acid. So does cystine. Does she have cystine? Probably not. So this lady has a uric acid stone. Come in all kinds of shapes. You look under a crystal, this is the way they'll describe it. They'll call it rhomboid or kind of this rosette shape. So you may get this on your boards. You know, they'll show you this urine crystal and say they had a stone and you have to put it together. They love to show these things because they're very specific to these specific stones. There's more crystals. All right. I don't want to talk about that stuff. All right, let's do another case. We'll make this the last case, okay? And then you can ask questions if you want. Now we got a 32-year-old lady. I think I've given it away already. I haven't even read it, but recurrent urinary infections. When you measure her pH, or as a, can I say stonologist? Is that a word? As the kidney stonologist, you go and you look at all of her urinalysis, and you just happen to make note that her urine pH is high. I can be honest, I usually pay very little attention to urine pH. But in kidney stones, I'm paying a little bit more attention. And I just happen to notice, boy, this urine pH is always high. And what's high urine pH? Usually like 6.5 or more, okay? And now she has this ridiculously large stone in her kidney. What does she have? You guys know it. Right, right. So what is this? Specifically, it's a magnesium ammonium phosphate. Well, what does that look like? Yeah, it looks like an antler or a staghorn, right? Because this is the renal pelvis, and then here are some of the calyces. So we call that Staghorn Calculi. That's the buzzword. Here's a KUB. What's wrong with this one? This is overexposed, so it's hard to see, but anyone see this stone? Right there? Staghorn Calculi. How about this? It's a little bit easier to see. Bilateral. There's another one. Here's the buzzword on the board, coffin lid. They'll show you this. Coffin lid is a magnesium, ammonium, and this the other ones could be on your step one. This has a high probability, and so would cystine crystals, the hexagon, just because they're so, I don't know why it's so rare, but the boards love to talk about it. So if somebody has the Staghorn Calculi, what do? How do you treat it? We can step back. Uric acid, I told you, was the best stone to have, right? Because I can dissolve it. I can give you potassium citrate. Citrate gets metabolized into bicarbonate, alkalizes the urine. Those stones eventually dissolve and go away. Or I can give you sodium bicarbonate, whatever. Same concept, alkalize the urine, stone dissolves and goes away. How do I get rid of that? Can I give a medicine to get rid of it? Nope. You better do surgery. Why do you have to do surgery? Well, it's big. We have lots of big stones we don't always do surgery on. The risk that it can obstruct that kidney. But the other thing is she keeps having recurrent urinary infections. So I give her ciprofloxacin for 3 days, a week, 2 weeks, whatever antibiotic, and she keeps getting infections. Why? Because that stone is infected and the antibiotic cannot penetrate into some of the porous parts of that stone. And so you clear the infection and then she just gets recolonized. She's essentially colonized with it, if you will, from the stone. So you have to take the stone out surgically. Sometimes we'll put people on suppressive antibiotics to help to a certain extent, but you've got to take it out. Yeah, medical therapy, rarely successful. That's good. All right, I don't have a case on this, but I just want to show you. Cystine stones are kind of yellow, but you guys are never going to see that. You're going to see this. This is I would say of all the stone crystals they're going to put on your boards is that. And don't ask me why. I think it's like the board's asking you about pheochromocytoma. Why the heck do we ask you about pheochromocytoma? You know, I can tell you I've seen a handful because I was at a large tertiary center. Otherwise, you're never going to see it. But we pontificate and think about it all the time, and I order tons of plasma metanephrines and 24-hour urine catecholamines, and I never find them for secondary hypertension. All right. You can get drug stones. Did you guys know that? So you can get pharmacological stones caused by, did you know this, Dr. Staudinger? And Denavir crystals. What the heck is Denavir? Yeah. So this is a drug that's used relatively commonly these days, right? HIV is now a chronic medical condition. It's not a terminal disease anymore. And it's not impossible that these patients could develop Denavir crystals, which kind of look like the calcium phosphate stones. You can get, what is a sulfa antibiotic that's the most commonly used one? Bactrim. There you go. You get Bactrim stones. Has anyone ever heard of amoxicillin? It's used all the time. Can cause stones and crystallization. And then we won't get into that. That's too much. Bottom line, kidney stone formation results from a complex interaction between lifestyle and genetics. When it comes to treatment, which I kind of skipped those slides just because I'll tell you the number one treatment is that, fluid, fluid, fluid. If your family member develops a kidney stone, you tell them, drink fluid. And how much fluid do they have to drink a day? Yeah, but what's like you quantify it for them. Yeah, we're metric. We're metric, huh? Not 3 liters, at least 3 liters a day. And what is the best barometer of how well hydrated a person is? Clear urine, or crystal clear urine, or a pale yellow. If you held it up to the light, you could see through it. Darker than that, they're not drinking enough fluids, period, okay? The next thing is we can change their, I didn't get into this with you, but we can actually change their diet. We can have them consume less protein. Higher protein diets are a risk factor for calcium stone formation. Actually, you can put them on a low salt diet. Why would a low salt diet be helpful, you think, in someone with kidney stones? You'll pee out more water? Okay, not quite. So if I consume a low salt diet, I mean, I'm like 0 salt, and what could happen to me from a volume standpoint, an intravascular volume standpoint? Go down. So what do we do when we have people that are syncopal or pre-syncopal, right? We say drink lots of fluids, eat a lot of salt, right? Help increase your intravascular volume, help prevent that from happening. Well, the same is true of, the opposite is true of salt. So if we put someone on a low salt diet, we put them at risk of developing hypovolemia. And we're intentionally trying to make them hypovolemic with a low salt diet, because what happens when you're hypovolemic? RAS, ADH, right? And so you reabsorb, you start concentrating your urine. And as you concentrate your urine and reabsorb a lot of stuff, you get a lot of paracellular reabsorption of calcium. So low salt diet long-term leads to less urine calcium levels, lowers urine calcium. It's kind of a roundabout way to get there, but that's true. And then you always want to check the stone, see what it is, and then we can treat it. So if you had a calcium stone and you had high urine calcium levels on your 24-hour urine supersaturation study, how could I fix that? What pharmacological drug could I give to fix the elevated urine calcium? Thiazide. Why would a thiazide diuretic help with calcium, urine calcium levels? Increases calcium absorption. You have to go back to your transporters, but essentially it's blocking an apical transporter, but it's activating a calcium exchanger on the basolateral side, and so you're reabsorbing more calcium, okay? So that's why we do that. And thiazides are very weak diuretics, so we're not going to volume deplete people really by giving them that. That would be bad, because what would a loop diuretic do to one, fluid status and urine calcium levels? It would increase urine calcium levels and it would make you volume depleted. So what do we do when someone shows up with abdominal pain, right? You guys have heard this story, or you will. Oh, I've got terrible abdominal pain. No one knows what's wrong with me. I've been scanned 1,000,000 times by every ER doctor in a 500-mile radius, and no one can tell me why I have abdominal pain. All my labs are normal, except everyone overlooks the calcium that's 14 or 13. So hypercalcemia can cause abdominal pain, and hypercalcemia is treated with IV fluids and also loop diuretics. Yeah, there you go. Questions? There's a lot of other stuff we can tell you, but that's probably more than you need to know. Anything? Yep.
So you mentioned different medications that can cause kidney stones, and one that caught my attention was allopurinol, which in my mind would you have a higher risk of uric acid kidney stones if you're on allopurinol, or would that cause a different kind of stone since you're lowering uric acid with allopurinol?
All of those drugs that I showed you that can cause urine crystals, they're relatively rare, okay? Don't let me backtrack my statement and not overemphasize those as common causes. You can see them. I put that in there more to just remind you that there are other possibilities. But in general, no. Allopurinol, I don't know if I've ever seen an allopurinol crystal, okay? In general, we treat people with uric acid stones not only by alkalizing the urine, but we lower uric acid levels with a xanthine oxidase inhibitor. Cheapest one available, allopurinol. Or febuxostat, that's the new one, right? But that costs a lot. Okay.